My name is Dr. Alex. I am not a licensed physician. I am not a cardiologist. And I am not going to tell you when to take your medication, because that decision belongs to your prescribing doctor, and only your prescribing doctor. What I am going to do is walk you through the science, clearly and honestly, so that the next time you sit in your doctor's office, you can ask the right question, not, should I take my pill in the morning or at night? That question is too simple. The right question is more specific. And by the end of this video, you will know exactly what it is. Stay with me through the full breakdown, because the conclusion is not what you expect. It is not morning. It is not bedtime. It is a third answer. One that requires knowing something about your own body that most people have never been tested for. And that piece of information, quote, which your doctor can get with a single 24-hour test, may be more important than the medication itself. Before we go deeper, I want to ask you one thing. If you take blood pressure medication, when do you take it? Just type it in the comments. Morning, night, split dose, whatever your routine is. Because by the end of this video, you are going to understand why your answer matters, and whether it is the right one for your body. Here is what most people do not know about blood pressure. It is not a single number. It is a rhythm. Your blood pressure follows a 24-hour cycle that is governed by your circadian clock, the same internal system that regulates your sleep, your hormones, and your body temperature. In a healthy pattern, blood pressure rises in the early morning hours, peaks during the mid-morning, stays relatively stable through the afternoon, and then drops by 10 to 15% during sleep. That nighttime drop is called dipping, and it is not optional. It is protective. It gives your heart, your blood vessels, and your kidneys a period of reduced workload every single night. A recovery window. Think of your cardiovascular system like an engine. During the day, the engine is running at operating speed, pumping hard, maintaining pressure, responding to stress and movement. At night, the engine is supposed to idle, slow down, cool off, let the components rest. When that happens, you are a dipper. Your engine idles properly. When it does not happen, when your blood pressure stays elevated through the night, you are a non-dipper. Your engine never rests. And over months and years, that lack of recovery accelerates damage to the arteries, the heart muscle, and the kidneys. Research published in the Canadian Journal of Cardiology and multiple meta-analyses have shown that non-dipping blood pressure patterns are associated with significantly higher cardiovascular risk, including heart attack, stroke, and heart failure, independent of what your daytime blood pressure numbers look like. Your office blood pressure reading can be perfectly controlled, and you can still be at elevated risk if your nighttime numbers are not dropping. This is the context that makes the timing question matter. It is not about whether morning or night is better in general. It is about whether the timing of your medication matches your body's specific blood pressure rhythm. In 2019, a Spanish research group led by Dr. Ramon Hamida published the results of the Hygia Chronotherapy trial. It was a large, long-running study. Over 19,000 hypertensive patients, followed for an average of 6.3 years. The patients were randomized to take all of their blood pressure medications in the morning or to take at least one at bedtime. The results made international headlines. Patients in the bedtime group had significantly lower nighttime blood pressure and a dramatically lower rate of cardiovascular events, including heart attacks, strokes, and cardiovascular death. The bedtime group also showed improved blood pressure dipping, meaning their nighttime readings, doctor, opts to a healthier range. The relative risk reduction was massive. Some analyses showed a 61 to 67% reduction in major cardiovascular events in the bedtime group compared to the morning group. The study was published. Cardiologists took notice, and millions of patients around the world started asking their doctors whether they should switch their pills to bedtime. But then something happened. In 2022, a British research team published the time study, Treatment in Morning versus Evening, in The Lancet. It was even larger than Hygia. Over 21,000 hypertensive patients, average follow-up of 5.2 years. Patients were randomized to take all of their blood pressure medications, either in the morning or in the evening. The result? No difference. Morning dosing and evening dosing produce the same rate of cardiovascular events, the same rate of heart attack, the same rate of stroke, the same rate of death from cardiovascular causes. The primary outcome: a composite of vascular death, myocardial infarction, or stroke, occurred in 3.4% of the evening group and 3.7% of the morning group. The difference was not statistically significant. And in 2024, at the European Society of Cardiology Congress, the BedMed and BedMed Frail trials from Canada confirmed the time findings. A meta-analysis combining all of these trials concluded that for most patients, the timing of antihypertensive medication does not significantly affect cardiovascular outcomes. The 2024 European Society of Cardiology guidelines reflected this, stating that patients should take their blood pressure medications at whatever time of day promotes the best adherence, which, for most people, is the morning. So how can two enormous studies reach opposite conclusions? The answer lies in methodology and population. The Hygia trial, while large and long-running, was conducted by a single research group in Spain. A 2022 systematic review by the International Society of Hypertension evaluated all existing studies on bedtime dosing and determined that all 8 studies, including Hygia, had a high risk of bias. The results were striking, but the methodology was questioned. The time trial, by contrast, was conducted across the United Kingdom with a broader and more diverse design. It is now considered the more methodologically robust of the two. But here's the nuance that most headlines miss. The time trial showed that for the average hypertensive patient, timing does not matter for hard cardiovascular outcomes. That does not mean timing never matters for any patient. There is a specific group of people for whom timing may still be important. And that group is defined by one thing. Non-dippers are people whose blood pressure does not drop by at least 10% during sleep. And research consistently shows that non-dippers are at significantly higher cardiovascular risk than dippers, even when their daytime blood pressure is well controlled. The Oman trial, published in 2025, randomized hypertensive patients to morning or bedtime dosing and found that bedtime dosing produced significantly greater nighttime blood pressure reduction and better restoration of the normal circadian dipping pattern. For non-dippers specifically, bedtime dosing may help restore the protective nighttime drop that their bodies are not achieving on their own. The 2023 European Society of Hypertension guidelines acknowledge this explicitly, stating that while convenience and adherence should guide timing for most patients, bedtime dosing may be considered in patients with documented high nighttime blood pressure. The key word in that guideline is documented. You cannot know whether you are a dipper or a non-dipper from a single office blood pressure reading. You need ambulatory blood pressure monitoring, a 24-hour test where you wear a portable cuff that takes readings throughout the day and night. That test reveals your full circadian blood pressure pattern, and it is the only way to know whether bedtime dosing might benefit you specifically. There is a second group for whom timing matters, but in the opposite direction. Some people experience what cardiologists call a morning blood pressure surge. This is a sharp, rapid increase in blood pressure during the early morning hours, typically between 5 and 9 in the morning. It is one of the reasons heart attacks and strokes occur more frequently in the morning than at any other time of day. For people with a documented morning surge, taking medication in the morning, so that peak drug effect coincides with peak blood pressure, may be the more protective strategy. Moving their dose to bedtime could leave them undercovered during the most dangerous hours. This is why the answer is not morning or night. The answer is, it depends on your pattern. and the only way to know your pattern is to measure it. The following is a composite illustration based on published research patterns. This is not a real patient. No individual medical history is being described. Margaret was 74. She had been on amlodipine for 11 years. Every morning, right after breakfast, her office blood pressure readings were consistently in the 120s, over 70s. Textbook. Her doctor said she was well controlled, and she was. During the day. But Margaret's daughter read something about nighttime blood pressure and asked her doctor whether Margaret should wear a 24-hour monitor. The doctor agreed. The results showed something that 11 years of office visits had never revealed. Margaret's blood pressure was not dipping at night. Her nighttime readings were nearly the same as her daytime readings. She was a non-dipper. Her heart had been running at full speed every night for over a decade. Nobody knew. Her doctor reviewed the data, consulted a cardiologist, and made one change. He moved one of Margaret's medications to bedtime. Not a dose change, not a new drug, a timing change. 6 months later, a repeat 24-hour monitor showed that Margaret was now dipping. Her nighttime readings had dropped 12%. Her cardiovascular risk profile had shifted, not because of a new pill, but because the old one was finally working with her body's clock instead of against it. That is what this conversation is about. Not headlines, not one-size-fits-all advice. A question your doctor can answer, if you ask it. Let me be as clear as I possibly can about what this video is and is not. This video is not telling you to change when you take your blood pressure medication. Do not do that. Not tonight, not tomorrow, not based on anything you heard in a video, including this one. Changing the timing of blood pressure medication without medical supervision can cause dangerous drops in nighttime blood pressure, increase fall risk, and create complications that are far worse than the problem you were trying to solve. This is a decision that belongs to your prescribing physician. Full stop. What this video is giving you is a question. The question is this: Doctor, do we know what my blood pressure does at night? Have I ever had ambulatory blood pressure monitoring? Am I a dipper or a non-dipper? That question, asked at your next appointment, opens a conversation that could reveal something your office readings have never shown. And if the answer leads to a timing adjustment, it will be made by your doctor, based on your data, at a pace that is safe for your body. That is how this should work. Not from a video, from a conversation. Here is the summary. The time trial tells us that for most people, timing does not significantly affect cardiovascular outcomes. And consistency matters more than clock position. The Hygia and Oman data suggest that for non-dippers specifically, bedtime dosing may help restore the protective nighttime dip. The morning surge data suggests that for PEO, plea with early morning spikes, morning dosing may be more protective, and the 2024 ESC guidelines say, take your medication when you are most likely to remember it, unless your doctor has a specific reason to recommend otherwise. Here's what I want you to do. In the comments, answer one question. Has your doctor ever ordered a 24-hour blood pressure monitor for you? Just yes or no. Because those two responses tell me something important about the gap between what the research says and what is actually happening in clinical practice. And if this video made you think differently about your health, watch the one that covers 7 things that if you can still do them between 75 and 85, the research says you are aging exceptionally well. It is the most positive video I have ever made. And the most important, it is on the screen right now. I will see you there. Stay informed, stay safe, and never change a medication without talking to the person who prescribed it first.